So I get loads of questions about how the anaesthetic machine actually works and what it does, so I thought I'd go through a quick tour of the anaesthetic machine. This is a Care Station 650. There are a whole bunch of different types, but anaesthetic machines all do one thing. In the bad old days, they used to anaesthetise people by simply dripping chloroform or ether onto a rag on someone's face, and they would breathe in the volatile fumes from this liquid ether or liquid chloroform, and that's what would drift them off to sleep. An anaesthetic machine does that, but a bit more scientifically. It makes a concentration that you can reliably give to the patient of vapor into a mixture of gas, and the patient then breathes that in. That's all it does. That's what the anaesthetic machine does, and on most modern anaesthetic machines you have a ventilator as well, and that will push air or your gas mixture in and out of the patient's lungs, and that is all that it does. It's just a complex way of doing it to make it really safe. So we'll go through it and I'll show you the bits that it does. So we'll start at the wall. This is the gas supply. So the anaesthetic machine is plugged into a whole bunch of gases from the wall supply. So white is oxygen, blue is nitrous, so nitrous oxide, which it's a bit of sedation, it's a bit of pain relief. It's bad for the environment, it works well. There's a whole argument as to whether you should give it or not. Black is just air, yellow is suction, and this clear one is anaesthetic gas scavenging. This is a special module on the side of the machine, which is trying to be better for the environment by suctioning up all the anaesthetic gases and preventing them from just being lost out into the atmosphere. So your oxygen and your nitrous, etc., all plumb down here into the back of the machine. They all have unique screw threads, which means you can't plug the wrong cable into the wrong wall socket, which means that you can't accidentally give the wrong gas. So that's one of the key safety features on the machine. Coming around to the front, we have the rotometers. So modern machines don't have these dials anymore. The old-fashioned ones all kind of look like this. So if you want to give a gas, you open up the dial, and you can see that that's starting to give some gas. You can see it coming out. Now this is actually an auxiliary oxygen supply. So this is just a spare backup in case the machine fails. This is just connected directly to the wall, and the oxygen just comes out of this little outlet here. So this is not part of the intrinsic rotometer system. It's just a backup oxygen supply, but that's how the old-fashioned rotometers would work. On this system we have these more modern digital dials, and even more modern machines have it all controlled on the monitor here, and it's all done electronically. But all you do is you simply give how many litres per minute of each gas that you want, and the machine will deliver it. And so you can work out what percentage you want. So if you give 2 litres of oxygen, 2 litres of air, you end up getting 4 litres total, and it's 50% oxygen. You can get the idea. The most important part of the machine is probably the vaporizer. This device is a really clever piece of kit, and what it does is essentially has liquid. So this one's a sevoflurane vaporizer, and every vaporizer is specific to the agent that it gives, because the volatility of each vapor is completely different. So they have to have different vaporizers. So a sevoflurane vaporizer will only work with sevoflurane. The liquid is put in the front here. You can see there's a dial like in your car, tells you how much you've got left. And then what this does is calibrates how much sevoflurane is being given into the breathing circuit. So you've got your mixture of gases that you want to give, and then you add in how much sevoflurane you want to give. And all you do is push this dial, and that has gradations on it which tell you what concentration of sevoflurane you're giving to the patient. This is what keeps the patient asleep. Obviously oxygen keeps them alive, nitrous will add to pain relief and reduce how much sevoflurane you need, and air you just use to make up what flow rate you want. Also on the machine we have suction, which is really important. So there's our suction, and that's just on the side here. Really important for airway management in case you want to get rid of secretions or blood. And so then once you've got your nice gas mixture, that's all the anaesthetic machine does. It then pipes it through to the ventilator. Now you can either ventilate a patient mechanically using the ventilator on now, so you can see it pushing down. That's how it's delivering breath, and that delivers through this breathing circuit, and I've attached it to this bag so you can see it ventilating this pretend lung. The ventilator is behaving differently because obviously that's not the same as a human lung, but it's showing you the tidal volumes that it's giving and how much pressure it's needing to give for that. So the ventilator is technically separate to an anaesthetic machine, but most anaesthetic machines now come with a ventilator as part of the system. And then you have two options. You can either have them on mandatory ventilation, so this will tell the ventilator to start giving breath, or you can put them on spontaneous mode, which means the anaesthetic machine will still give a flow that you've set through this breathing system, but it won't actively ventilate the patient. So if the patient is breathing spontaneously, you can have them on this setting, and then it allows them to breathe however much they want, and then you can just monitor that, and you can see it's not actually giving any breaths at the moment. Alongside with a ventilator, we have this bag. Now the bag, you've seen in previous videos, does three really important things. One, it acts as a monitoring system. So if the patient is breathing, this bag will collapse and fill up as the patient inhales and exhales, and that tells you their rate of breathing and whether they're getting good tidal volumes. It also tells you that they are actually breathing. Second thing is it allows you to manually ventilate the patient. You can put as much gas, that's a 2-litre bag, so you can squeeze that and that will push air through the breathing circuit, and it means you can support the patient's breathing. So if you don't want to put them on the ventilator because you want them to breathe by themselves but they haven't started breathing effectively yet, you can just give them some breath. Or if you're trying to resuscitate them if they have any problem during the procedure, that's what the bag's for. The final thing it does is it acts as a reservoir of fresh gas, so they don't breathe back in any of the gas they've exhaled. This little widget here is the APL, or adjustable pressure limiting valve. So that's on minimum, which means if I squeeze the valve, then it's just all going to vent out through the safety release valve. So it means that there isn't too much pressure in the system. So it means there isn't too much pressure in the system. I can increase this pressure all the way up to 70 centimeters of water, and now you'll see there's a lot more pressure in the system. And the machine doesn't like that because that's a lot of pressure. And if I release that pressure, should drop back down to a much nicer number. There you go. And finally, down here we have the soda lime. This compound is very good at absorbing CO2. So we have a circle breathing system. So that's why this breathing circuit has two limbs. One is the inspiratory circuit and one is the expiratory circuit. The idea being the patient can inhale through one of these lit tubes and then breathe in, and then exhale, and it goes down the other one, and it goes back into the machine. And that means you can recycle oxygen and sevoflurane really efficiently, and you can put the flows really, really low, and you're not wasting lots of gas. The problem is they would also then start breathing the CO2 over and over again. So to stop them breathing CO2, you have something to absorb that CO2, and that literally holds onto it, and then you replace the granules inside the canister. And this will either change colour from white to pink or pink to white, depending on what soda lime you're using. The other type is called barrel lime. The principle is the same. They absorb CO2, take it out of the system, and stop them rebreathing. So that's it, literally the whole anaesthetic machine. All it does, this bit gives a known concentration of gases and vapours, and then the ventilator lets you push air in and out of the patient. That's the whole machine. You then have some extra bits with some suction. You've got the soda lime to absorb CO2 and the breathing bag to help support the patient's breathing, but that's it.